Thank you for that introduction, Dr. Nestor. All right, I'm excited to talk to you guys about some of the research I've been working on over the last few years. And my topic is when DAT or that is not enough, the role of enhanced DAT and elution studies in hemolysis. I have no disclosures, sadly. And then as my outline, we're gonna take a whirlwind tour. So first we're gonna just talk about hemolytic anemia in general. How do you diagnose it? What is your differential? Then I'll go into DAT testing methods. What are some of the limitations of this testing? Then elution studies, some of the, again, methods and limitations of that. I'll talk about part one of some of the research I've done where I evaluated how do clinicians actually use the results of our elution testing in their management, or do they use it at all? And then I'll talk about enhanced DATs or the Supercoombs test. When are opportunities to send this test when it's appropriate? And again, looking at how often are clinicians sending this test and are they using those results to help with clinical management, if at all? And so we're gonna start with an overview of hemolytic anemia. This is something that I see all the time as a hematologist, and it's very bread and butter. You have a patient with anemia and you're trying to figure out why are they anemic. So you're going through, are they macrocytic, microcytic, normocytic? They're normocytic, their reticulocyte count is high, their bilirubin is up, so now you're concerned for hemolysis. And then the next step when you are thinking it's a hemolytic hemolysis is that you're trying to figure out, is it antibody mediated or not antibody mediated? So you send off a DAT. And your DAT could either be positive or it could be negative. If your DAT is negative, then I'm thinking, okay, it's probably not immune mediated. And the differential here could be mechanical hemolysis. The patient has a heart valve, maybe they're on ECMO, something is going on with them. Membrane disorders, this is hereditary spherocytosis, hereditary elliptocytosis, and then hemoglobinopathy, so sickle cell disease being the classic hemoglobinopathy we think about with a hemolytic anemia. And then if your DAT is positive, I actually would say to hematologists it's exciting when the DAT is positive because now you're thinking immune mediated. This is something I can treat. And within the immune mediated, the differential is still fairly broad. I'm going to mention the two more common diagnoses people think of, which is warm autoimmune hemolytic anemia or WAIHA, and then cold agglutinin disease or CAD. All right. So the direct antiglobulin test, the question we really want to ask ourselves is there an antibody on the red blood cells? So we're going to put on our laboratory coats and we're going to see what do we need to do to determine this. And the thought being that if there's no antibodies bound to my red cells, I'm going to have a negative DAT. If there are antibodies bound to my red cells, I'm going to have a positive DAT. And why does it even matter if an antibody is bound or not? The reason it matters is because in the heavy chain of the antibodies, there is an Fc portion that has two binding sites. One is the complement binding site, and then the other is the Fc receptor binding site. And these can be clinically significant. So if you have binding of the Fc receptor binding site, you're going to have red cell destruction through phagocytosis, through the liver, through the spleen. You're going to have spirocytes that form elevated bilirubin, or what we call extravascular hemolysis. If you have hemolysis mostly through your complement site, now we're thinking, okay, this is more complement mediated. So you have a MAC complex that forms and your red cells basically hemolyze in circulation. You have schistocytes, you have hemoglobinuria, you'll also have decreased haptoglobin and increased LDH, which you can actually see a little bit in both, but you think mostly with intravascular hemolysis you would expect that. And I will say in my training as like a pediatrician and a peds hemonc, I always thought that these were two completely different things, that IgG is extravascular hemolysis, this is what I expect, and IgM is intravascular hemolysis, this is what I expect. But as you saw in the antibody, an IgG can actually activate complement, so it can't activate the other pathway. So I've shifted my thinking to actually this is not one or the other, it's actually a continuum. I've seen plenty of patients with warm that have positive complement, that have signs that they are having some degree of even intravascular hemolysis. And clinically, I've seen patients with really strong warms where they've started complement inhibitors in order to get them to respond and their anemia to resolve, and they've responded really well. So really, it's a continuum. It's not two completely separate things. Now let's go on to DAT testing. So the way a DAT is performed, on the top you have a red cell that has antibodies not bound to it, and on the bottom is a red cell with antibodies bound to it. And the first thing we do in both situations is we would wash away any unbound antibodies in the plasma. And the reason we do this is because we don't really care about the antibodies in the plasma. That's what our antibody screen is for. We only care about the antibodies that are bound on the red cells themselves. So once I wash it away, then I add an anti-human globulin reagent. And that reagent will bind to the antibodies that are already present. So it binds to the antibodies that are bound to my red cell. Then I centrifuge and I evaluate for agglutination. So if there is no antibodies bound to it, no agglutination. And if there are antibodies, then I'll see agglutination. And the HG reagent that we use matters. So we ideally think that we're looking for two different kinds of antibodies, again, IgM and IgG. What's interesting about IgM is that we're not actually directly looking for anti-IgM. We're actually looking for the presence of complement. So some of the more stable forms of complement are C3b, C3d. So we're actually looking at antibodies against that. And through that, we're kind of inferring, oh, there's a lot of complement activation, that it's probably an IgM. But that's not always the case. And then the other situation is an IgG that's positive. And like I said, IgG can in fact activate complement. So you definitely have IgGs that can have positive reactivity with the HG reagent for complement. And then the different reagents that we use for the HG, there's a polyspecific, which is a blend of your different antibodies. And we use this kind of as a screening test. So if your polyspecific is negative, we stop right there. But if your polyspecific is positive, then we'll do all of the monospecific testing, looking specifically for IgGs and complement one at a time. And these are the strengths of agglutination in a tube test. So you can see that the reaction strength really just talks about how much of agglutination you have. So 4+ would be the ideal that you see, but 1+, you still have some degree of agglutination, but it's not necessarily negative. And we can talk about why that's important later. So in the ideal scenario, when I do the HG reagents, I do a polyspecific, and I think, okay, this is going to tell me if there's either IgG or C3 bound to it. Then I do the monospecific IgG, and if it's bound, then I think, okay, this is a warm antibody, warm reactive. And then if there's complement bound to it, now I'm thinking it's a cold reacting antibody, which tends to be IgMs. But again, remember that there is a continuum between extravascular and intravascular hemolysis between the two antibodies. Okay, so the DAT is positive. Now what? Do I have a diagnosis of an immune hemolytic anemia? It's important to note that a positive DAT alone, even in the absence of hemolysis, we're taught. So a positive DAT alone in a patient who's not hemolyzing does not mean they have hemolytic anemia. But I think a positive DAT, even in a patient who is hemolyzing, does not actually mean hemolytic anemia, which can make it confusing. When a patient has a concern for hemolytic anemia and the DAT is positive, there's a couple of different types of reactions we can see. So either the IgG is positive, the complement's positive, or they're both positive. So if the IgG is positive, most commonly I'm thinking, okay, it's an autoantibody, so we're thinking about a WAIHA. Or it could be an alloantibody, and this could be what we see with hemolytic transfusion reactions that the LMRs get called about. It could be with hemolytic disease of the fetus and newborn that we see on cord blood samples. And then if both of them are positive, it doesn't mean there's two different antibodies. Oftentimes, the IgG strength will be much stronger than the complement, and it just basically tells us it's still an IgG that can activate some degree of complement, and our differential's about the same. And then on the other hand, we can definitely see if it's only positive for complement or the complement strength is much stronger than the IgG reaction, then we're thinking about cold antibodies, so things like cold agglutinin disease, cold agglutinin syndrome. And then finally, we don't think about this as much, but drug-induced hemolytic anemia is always on a differential, and that can have two pathways, either a drug-dependent antibody or drug-independent antibody. So you can see that a positive DAT, your differential is still pretty broad. You have it diagnosed, but you haven't exactly diagnosed what kind of hemolytic anemia your patient has. So based on a positive DAT alone, a WAIHA would respond to steroids, but all of the other things on the differential potentially won't. So then you have to ask yourself, is there a test that can help me determine the specificity of this antibody? And now we're going from being laboratory scientists to really being detectives. So what antibody is it? I know there is something, but I want to know exactly what it is. Now we'll talk about elution testing. And elution testing is helpful because it determines the specificity. And I really want to emphasize, because I know in my training I didn't realize this until I became an attending and really far into transfusion, that just because you have a positive DAT, it does not mean it's an autoantibody, and it does not mean your patient has WAIHA. Autoantibodies are definitely on our differential. These are antibodies against high incidence red cell antigens that will react to other red cells, the patient's red cells. They'll just react to about anything. And then alloantibodies are antigens that your patient doesn't express. So they're not expressed on their own red cells. And the way that we determine the specificity is that we'll do an elution. So here we have a patient with a positive DAT. What we do is we remove the bound IgGs, and we unbind them. And what this does is it gives us more room to figure out the specificity by choosing which red cells we want to have the reaction against. So we'll pick a panel of red cells that I know what they express, and I'll decide based on where the antibodies are binding and not binding what the reactivity is against. And you could see either the antibody could bind to all of my reagent red cells, it could bind to maybe one of them, it could bind to none of them. Those are the different clinical scenarios. And I want to make a point here that can be confusing for people who don't do this very frequently, is that the DAT is performed on the patient's red cells. The eluate is performed on reagent red cells. Okay, it's a very big difference, a very big nuance. And in the eluate, we're removing the antibody of interest, and we're testing it against various reagent red cells to determine specificity. So scenario one with your elution, you're going to see that whatever is in your plasma that you eluted off is going to react with every red cell. You're getting agglutination. So I'm going to say that's a panagglutinin, and that's most consistent with WAIHA or just a warm autoantibody. Or maybe that elution is just reacting against specific red cells and not against others. Let's say it's reacting only against big E positive red cells, but not those that don't express the big E antigen. Now I'm thinking, oh, it's an anti-big E that I eluted. And maybe this patient in the most common scenario got a transfusion, they're E negative, they got an E positive transfusion, and now they're having a delayed hemolytic transfusion reaction. And this is, I think, when your eluate results are positive and they can give you a clear diagnosis, at least for DHTR, I know it's really exciting for us in the blood bank. It feels like a straight shot through the hoop, like, oh, I got this. Like, I know what the diagnosis is. But then there's always this other scenario where maybe your eluate's negative. And you thought you had the diagnosis, but now you're not sure anymore, because why didn't you elute anything off? And when that happens, we call it no antibody eluted or non-reactive. And how do you interpret that? And I get this question from residents all the time, because the clinicians will call them and say, hey, can you interpret this DAT for me? The DAT is positive, the eluate's negative. What does that mean? And the first thing we talk about is that it's false positive DATs. So some degree of healthy blood donors will have positive DATs. This has been shown in multiple studies. And then within hospitalized patients, the degree of having a positive DAT is actually higher. Some papers say up to 15%. And these patients don't have hemolytic anemia, but maybe they have some degree of complement sensitization or IgG sensitization. Maybe they have elevated serum immunoglobulins because of the underlying diagnosis. Maybe they have rouleau formation or even infections or medications. So there's a lot of different things that can cause the DAT to be a false positive. And then the other thing is that maybe it's not a false positive. Maybe it is a true positive, but the patient has a cold. Because when we do the elution that we run in our blood bank, our standard elution techniques are optimized really for IgGs. I know immunology here has an elution that's more specific for IgMs, but ours is really specific for IgGs. There are elutions for IgMs, they're not widely used, but for cold agglutinin disease, you're not gonna get a positive elution. You're always almost gonna get no antibody eluted. And there's other tests that can help you, like thermal amplitude titers, or like doing DTT treatment to determine if they're clinically significant or not. And then the third scenario in which you might see a negative eluate is drug-induced hemolytic anemia. So going back to the two pathways, you have the drug-dependent antibody and then you have the drug-independent antibody. So in the drug-independent, you might get an eluate that shows a panagglutinin, but it's only one of the 4 types of drug-induced hemolytic anemia. In 2 of the other ones, what we see is that it's drug-dependent. So what's happening in drug-induced hemolytic anemia is that the antibody is not specifically against your patient's red cells. It's actually when the drug or the hapten is bound to the red cells. So that's what the antibody is against. So when I elute this off and I get the antibodies by themselves and I'm testing it against a panel of like standard reagent red cells, I'm not gonna get a reaction because the hapten's not there. And in this situation, if you have a high clinical suspicion, the result would be to send out a drug-induced hemolytic anemia panel to a specialized reference lab. And what they would do is they would actually test the reagent cells in the presence of the drug solution. And they might even ask you to ship the drug yourself for the testing. And what they will do is do the elution in that presence, and you can see once that hapten is present, then you actually will have reactivity. So I think the limitations for the elution and why, in my training, we went as far as positive DAT and elution was never mentioned. In my clinical training is because, one, the lab really doesn't have a standardized practice for when to perform elution studies. In most places, this is a really specialized test. A lot of labs can't even offer to do that testing. They would have to send it out. And oftentimes, they're not repeating it every time the same patient has a positive DAT. They'll have a protocol. We'll do it like once every 3 months or something like that, or if something changes. So because the testing is not happening consistently, I think clinicians don't know to look for this test as a follow-up. And then the other end is that the clinicians don't really know what is this gonna show me? And it's because there's a lot of positive DATs that are gonna have a non-reactive eluate, one paper cited as high as 90%. And the classical thinking has always been, okay, if your patient has a positive DAT and a negative eluate, then you're thinking either a drug-induced hemolytic anemia, or you're thinking a false positive DAT and you just end the diagnostic workup and your patient doesn't actually have a real antibody. That's kind of the 2 big ways that people think about that situation. So this led to my research question, which was, well, what is the clinical utility of all these elution studies that we're doing? Because we are doing them on site here. How do the clinicians look at this result or not look at this result in their interpretation of hemolytic anemia? And if a patient has a negative eluate, are those patients only being diagnosed with drug-induced hemolytic anemia, or are they being diagnosed with something else? So for my study, I did a retrospective review. We looked at over 3 years of DATs that were sent out. Then we only looked at provider-ordered DATs. So for people that rotated through the blood bank, we do DATs as reflex testing all the time when we do an antibody screen or on cord blood samples and all these other issues. But I only looked at provider-ordered ones because the thought would be they'd only order if they were concerned for hemolysis. And if it was a positive DAT, then I determined, was the elution positive, negative, was it not performed? And then I looked at if they were diagnosed with a hemolytic anemia, or were they not diagnosed with a hemolytic anemia, and what was the exact diagnosis. Then I compared specifically the patients who had a diagnosis of immune hemolytic anemia who had a positive eluate versus a negative eluate. And really what I was trying to see is the patients who have more clinical hemolysis, are they more likely to have a positive eluate versus maybe a patient that has a worm that's not as clinically significant or really easy to treat, which has a negative eluate. And so I looked at laboratory markers of hemolysis, such as hemoglobin, reticulocyte count, transfusion needs, and also bilirubin. So I identified over 5,600 samples, and of those, 717 were provider ordered. I removed duplicates because sometimes the same patient had multiple DATs sent over the course of the same time, this time period. So I found 623 unique patients that had DAT sent. And then of these, 191 were positive and 432 were negative. And of the negative DATs, 3 patients were diagnosed with some kind of immune hemolytic anemia. And of the positive DATs, if the Elliott was positive, that was the smallest group. It was only 36. And 18 were diagnosed with immune hemolytic anemia. If the DAT was negative, we had a lot more of these patients, and only 19 were diagnosed with immune hemolytic anemia. And then if the Elliott was not performed, only 3 patients of this smaller group was diagnosed with immune hemolytic anemia. For the purposes of the next few slides, I only looked at the Elliott positive and the Elliott negative group to be able to compare those outcomes. So Elliott positive had a 50% chance that they were going to have a diagnosis of immune hemolytic anemia versus 14 in the Elliott negative. And the most common diagnosis was warm autoimmune hemolytic anemia, or WAIHA, and that was mostly in the Elliott positive group, followed by either cold agglutinin disease or a mix of warm and cold agglutinin disease was the second most common. And then the third most common diagnosis was a drug-induced hemolytic anemia. Both CAD and drug-induced hemolytic anemia were more common in the Elliott negative group. And in terms of treatments tried, again, my thinking being maybe the Elliott negative groups responded to steroids and didn't need rituximab or any other types of therapy. But there was actually no difference between the 2 groups except when it came to drug discontinuation, and that makes sense. So in the Elliott negative groups, they were significantly more likely to have a drug discontinued. So then I looked at positive predictive value and negative predictive value of just the positive DAT alone to predict immune hemolytic anemia. This is not something new. This is something that's been looked at in the literature plenty of times. And you'll note that similar to what's been reported, the negative predictive value for a DAT is actually really good. So if your DAT is negative, most likely your patient doesn't have a hemolytic anemia. But the positive predictive value is actually very low. It's only about 22%. And the literature has reported rates of about 24 to 40% for the positive predictive value. And again, the reason for this is because a lot of people can have false positive DATs. So again, up to like 8 to 15% of hospitalized patients, if they got therapy such as IVIG, depending on their underlying condition, you can have a false positive DAT. And then I looked at how good is a DAT with a positive Elliott. So those patients that had both a positive DAT and a positive Elliott, how good are we at diagnosing immune hemolytic anemia in those patients? And this is something that actually has not been looked at before. And I noticed that when we did this, the sensitivity did fall to 48%. So we do have a lot of patients who have negative Elliott's that still have a diagnosis of immune hemolytic anemia. However, the positive predictive value improved to 52%, really accounting for those false positive DATs that we see. Looking at things like the reaction strength, so I noted that patients that had a stronger reaction were more likely to have a positive elution. So usually their reactions were 3+ or higher. And then those that had a negative elution just had a weaker strength. And comparing the laboratory parameters, I didn't show the data, but there was actually no difference in terms of degree of hemolysis if we looked at things like hemoglobin, reticulocyte, LDH, bilirubin between the 2 groups. And drug-induced hemolytic anemia, as I predicted, was more likely to be diagnosed in the Elliott negative group. So your odds of having a drug-induced hemolytic anemia are about 8 times higher if your elution is negative. However, only 1/3 of those patients were actually diagnosed with drug-induced hemolytic anemia. In 1/3 of the patients, they were diagnosed with cold agglutinin disease, and 1/3 of the patients, they were actually diagnosed with a warm autoimmune hemolytic anemia. While drug-induced hemolytic anemia was a more common diagnosis, it wasn't the only diagnosis. So going back to the research questions that I had, what is the utility of an elution study? The answer that I got is that a positive elution can raise your positive predictive value from 25 to 52%. And a positive elution does correlate with a stronger reaction, but it doesn't necessarily correlate with a stronger degree of clinical hemolysis. So whether your patient's elution is positive or negative is not really going to help you predict whether they're going to have more or less severe hemolysis. And then the second question, does a negative eluate rule out immune hemolytic anemia? And the answer really is no. It does not end your diagnostic workup. You have not ruled out hemolytic anemia because your eluate is negative. It should actually increase your suspicion for a drug-induced hemolytic anemia, but a good subset of these patients were still diagnosed with a cold and WAIHA. So going back to the scenario where we're looking at antibodies on these red cells, when the DAT is positive, it's really helpful. And I can tell you in the lab and as a clinician, it's really exciting when you get a positive DAT. But what about if you're suspicious for an antibody and you get the opposite? You get a negative DAT. How far do you keep searching for that antibody? How far do you go? This is where we're going to talk about enhanced DATs. There is something called a DAT negative autoimmune hemolytic anemia. It's been reported maybe 10% of cases are DAT negative autoimmune hemolytic anemia. So the clinicians are looking for this. They're trying to diagnose this in their patient where they have no other reason for why they're hemolyzing. And then in a case series, they noted that if you use an enhanced DAT or Supercoombs, you can actually decrease your rate of DAT negative hemolytic anemia. So meaning that you actually can detect the antibody by doing this more specialized testing. So now we're going from being plain old scientists to really being super scientists and looking at this enhanced DAT or Supercoombs test, as people call it. So what makes this test so super? All right, the first thing we account for when we send out these tests is that they're all specialized tests that are done at specific reference labs. So the first thing they'll do is they'll just repeat a DAT. So they'll just repeat a regular DAT and sorry, the IgG, that shouldn't be there. It's just a regular DAT that they'll repeat, same standard one that we do in our own lab, but they'll essentially accounting for technical issues. And I will say half the time, that's all they need to do because they actually will get a positive result. And then the second thing they'll do is that they'll look for low levels of IgG bound via different methods. So the thought behind is that as healthy individuals, we can have some degree of IgG bound to our red cells, and that's okay. But a DAT is really meant if you have over 300 to 500 molecules of IgG bound to your red cells. But then you have these patients in between where maybe they don't have quite as little or quite as many, but they actually can still be contributing to a warm autoimmune hemolytic anemia. So that sensitivity assay is really looking for that in-between group where you're looking for those low levels of IgG. Then you can also look for low affinity IgGs via different methods. You can also look for IgA, so a completely different antibody. We often don't think as causing hemolysis, but actually there have been reports that IgA can cause hemolysis, immune mediated, so looking specifically for that. And then lastly, if you remember, we're not actually looking at IgM specifically, we're looking at complement. But sometimes you might have IgM that's not activating that specific complement that you're looking at, or maybe it's being used up too quickly, or it's not doing exactly what you expect it to. So there are actually anti-IgM Hg reagents that are available, or flow cytometry to look for that. And we do get requests. So we've had our LMRs screen enhanced DAT send out tests for the last few years, and these do come up very frequently. And the first question we always want to ask, did they even have an in-house DAT? Because sometimes the answer is no, they haven't. And my concern really was, we're looking for these like low level, low affinity IgGs, and like how significant are these? Because if Dr. Hess would always say, if you look closely enough for a cold, you'll find one. So how clinically significant really are these antibodies that we're going through so much work to look for? And for this, I did a retrospective study. I looked at all of the enhanced DAT sendouts from January 2017 to January 2024. I did this with Sarah Kim. And we looked to see, okay, all of these patients had sent out a Supercoombs test. They have an in-house DAT or not, and what were the results of the DAT? And then we took it one step further and we asked, what did the clinicians do with these results? Did they follow them up? Did they change their management? Did it actually lead to a diagnosis? So we found that there were 30 patients with enhanced DATs that were sent out, which is actually not too many. And then 2 patients we couldn't locate the records of. Of those, 28 So that leaves us with 28 send-outs. 2 patients had actually, I apologize, I think this is written incorrectly, but there was 2 patients who did not have a DAT that was done in-house. But of those 28, 11 had a positive enhanced DAT send-out, and 17 had a negative enhanced DAT result. Of the ones that were positive, there was one that it was actually unclear. The result was a failed autocontrol. And then of the 10 that were positive, cold agglutinin disease were diagnosed in 4 patients, autoimmune hemolytic anemia in 3 patients, and then 3 patients, despite the DAT was being positive, they actually felt like it was due to the patient's underlying disease. So either they had a heart valve or they had an enlarged spleen or something else was contributing to the anemia. And then of the negative DATs, 1 patient actually had a historical cold, so they were still diagnosed with that. 2 patients were diagnosed with DAT negative autoimmune hemolytic anemia, closer to about 3%, which is what was reported in the previous paper. And then 14 patients, they just said, okay, it's not hemolysis, it's due to the patient's underlying disease. So my thought being that, positive DATs must always change management, and actually wasn't true. So it only made changes in management for about 6 patients. 3 that had autoimmune hemolytic anemia and 3 that had colds. And then it didn't really change management in the other patients, in the 4 other patients. And it's because 1 patient already had the diagnosis. So although the enhanced DAT found it, they already had the diagnosis and they would have treated them exactly the same. And then 3 patients, despite it being positive, they still felt like it was too weak of an antibody to cause the degree of hemolysis they were working up. So 60% it changed management and 40% it did not change management. So going back to my question, do enhanced DAT results alter clinical management? I think the answer is yes, maybe in about 50% as reported. Ours was a little bit lower, but have a positive rate. And then even if you have a negative enhanced DAT, it can still help because those patients were diagnosed with DAT negative autoimmune hemolytic anemia. And then a positive DAT actually didn't confirm a diagnosis of autoimmune hemolytic anemia, and some of the patients, they still decided this antibody wasn't significant enough. All right, so we went from being plain laboratory scientists to detectives to superheroes to really look for these antibodies that could be implicated in hemolysis. So what are the take-home points from my talk? So with a DAT, a positive DAT, I will say, does not mean immune hemolytic anemia. A DAT alone has a very low positive predictive value for making the diagnosis. So you should have a really high clinical suspicion. For an elution, a positive elution can further improve the positive predictive value of your DAT. And then a negative elution can help steer you towards a diagnosis of maybe cold agglutinin disease or drug-induced hemolytic anemia. But really, it shouldn't end your diagnostic workup if you have high suspicion. So you shouldn't just say, oh, no antibody was eluted, there's no antibody implicated in my patient's hemolysis. And then the third scenario with the Supercoombs, a positive enhanced DAT also does not mean immune hemolytic anemia. As I showed that some of the patients with a positive DAT didn't actually get diagnosed with immune hemolytic anemia. Enhanced DATs can help with the diagnosis for sure. And even if it's positive or negative, it can help make the diagnosis a little bit clearer and change the management for these patients. All right, and with that, I'll take any questions. Yeah, Connor.
Sorry if you mentioned this, but the enhanced test, does that also check for the IgA subtypes?
It just looks at IgA. They almost never have to go to that step because they take a stepwise approach. They'll repeat a standard DAT, and then if it's positive, they'll stop right there. And then they'll look for the low affinity, and then they'll look for the weakly reactive cold. So they almost never go to an IgA step, but I don't believe they look for subtypes. I think they just look for IgA in general. Yeah.
Have there been any reports of like IgE or anything?
That's a good question. I actually don't know. I know IgA has been reported. I don't know about the other ones. Yeah. Oh, yeah, absolutely. Sorry. We'll do this. Yeah. All right. Yeah.
But forgive me if you said this and I missed it. In I guess either of your studies, but really the first one where you're looking at the sort of predictive value of the DAT, you started with providers who had ordered the DAT, right? So assuming that that's suspicion. But in how many of those patients was there laboratory evidence that there was active hemolysis? And so to what extent does the low predictive value represent maybe suboptimal ordering? And if you just sort of splice that in, or subset out into just folks who have lab evidence of probable hemolysis, can you increase the predictive value there?
Yeah, that's a great thought. I do have that data on all of the patients, but I didn't actually analyze it for the whole group. I just looked at the ones that did end up having a diagnosis of immune hemolytic anemia. But I think that's a great thought. Like if we really increase our clinical suspicion, if we really emphasize you should only be sending on patients who you have high clinical suspicion for, how much can we improve the sensitivity of this? Yeah, that would be great.
In the population that had a negative DAT but was still diagnosed with an autoimmune hemolytic anemia, especially those that had a negative, like Supercoombs, right? How confident do you feel in those diagnoses? Can you comment on that?
So I think with a lot of the diagnoses, even the patients that had like positive DATs and negative eluates that still got diagnosed with a worm, there's not really a way for me to confirm whether that was like the appropriate clinical diagnosis. So that's why I tried to look at, were they more likely to get like rituximab? Because that, if they're not responding to steroids, then you do second line therapy. I also looked at complement inhibitors and didn't really see, I think my patient population was too small. I didn't really see, because my thought would be that if they didn't have the right diagnosis, then they wouldn't respond to steroids and then they'd end up going to like second and third line therapy. But yeah, we just didn't have the numbers to be able to pick up on that. As a clinician, I have not diagnosed DAT negative autoimmune hemolytic anemia. I know there's people that have. In my own practice, when I was a fellow, there was a child that I took call for who did have that diagnosis, DAT negative autoimmune hemolytic anemia, but it actually turned out they had pulmonary alveolar hemorrhage. So actually their anemia and their high retic count was due because they were having bleeding and they were trying to compensate for it. And it actually was not the right diagnosis in that patient, but that's the only case I've had. I know in adults it's diagnosed much more frequently and I don't know what the outcomes are. But it's definitely, the evidence is strong that it's a real entity that's out there. Yeah.
For patients that have a true warm auto, or that you think is a true warm auto, but don't have hemolytic anemia, what do you think accounts for that? Antigen density?
For making the autoantibodies, I mean, we pick up patients, I think, like I said, some people just have some degree of antibodies that are bound to it. It may or may not be clinically significant. So why would you have a warm auto when it's not causing hemolysis? That's a good question. We pick it up all the time in our testing. I don't know if someone has a better understanding of that.
We see it all the time in pregnant patients. Yeah. So I just think pregnancy is a bit of an autoimmune state. In fact, it rarely causes hemolysis in pregnancy. It just gets in the way of your cross-match.
I'm curious if we know why, anything about mechanism.
Yeah, I don't know about the mechanism, but I have seen that in patients that have like lupus, like all these autoimmune diseases, they do tend to have higher rates of having a positive screen with a warm auto and a positive DAT. Yeah.
So I have sort of an operational question. Obviously, you want to write these up and get it published, but are you thinking about how to sort of either protocolize send-out ordering or protocolize sort of DAT requests? And if not, either take that, automate it and take it off the residents, or give them some sort of very structured guidelines for send-outs?
Yeah. I think the whole reason why we first started, because the LMRs were not getting called for every Supercoombs send out, is my understanding, but it's actually not orderable in Epic, so they did have to go through the miscellaneous send out. So I think they were still getting called, but there wasn't like an official pathway for it. We realized that some of those patients did not have in-house DATs, and that was our reason for getting the LMR involved, was that if they have an in-house DAT, if they haven't had one, then we should do one here first. And if it's positive, then we can potentially avoid this test that costs like significantly more to get the same result. So that was the thought process behind that. So I'm happy to re-explore. I don't know how much the residents are getting out of being involved in these cases. If they're looking, like if they're talking to the clinical team about, oh, could it be drug mediated? Maybe you don't need to send a Supercoombs. Maybe you're looking for a drug-induced hemolytic anemia panel, because that's where people get confused. If they're looking for drugs, they don't know what the right test is to order. So my other thought was they can help guide them towards the right test. Or if they look at the reaction of the DAT and they see actually the complement's really strong, or maybe like the DAT is positive, but the eluate was negative, and now the provider wants to do like a Supercoombs send out. But the complement's really strong, that, oh, maybe that's not the test you need. What you need is like a cold, tighter thermal amplitude, and that could better help you with your diagnosis. So the thought was really that they could help them, guide them to the right test, because right now, what I think is happening is like if the DAT is negative, they're suspecting hemolysis and they don't have anything else, and they'll send a Supercoombs. Or if the DAT is positive but the eluate is negative, potentially they're sending a Supercoombs because they still don't have a clear answer for what's going on.
So really a call for a lab med consult.
Yeah, I think so. But I'm happy to take feedback from the LMRs if they have on that call that they get. So, yeah.
Jim, very, very cool. With the elution testing, there's the sensitivity specificity trade-off. We're adding that test, like you do increase the positive predictive value, but you're also then going to miss part of that is that part of your along with the negatives being shuffled off, some positives are. So kind of almost connected to Josh's point, if you were thinking about operationalizing that, how do you think about that trade-off in the patient population? Like what is the better side of that coin to fall on in terms of missing positives or over like ending up with low predictive value?
Yeah, I think to do that, I really need to understand those patients that had a positive DAT and negative eluate and were still diagnosed with an immune hemolytic anemia, if that was like the right diagnosis. And it's really hard to do that retrospectively. So they were treated as such, and the degree of anemia was so different with each patient. But I think I'd really have to have that piece to say how we can optimize that test. And maybe if we find that all the patients who actually had a positive DAT and negative eluate, actually most of them didn't have, the diagnosis wasn't true. It wasn't an immune hemolytic anemia, it was actually just the underlying disease. So I'd have to think about how we would get to that information retrospectively or prospectively.
I agree. I think it's a true full consult, because so much of it is clinically what is the patient doing.
Mm-hmm.
So I like your LabMed 685 up the pretest probability before you order the test. But a lot of drug-induced hemolytic anemias, it's the story. It helps to have the positive DAT, negative elution, but you spend a lot of time tracking back which drugs are they on, when did they start it, when did the hemolysis start, to try to nail down that that's what's going on. Because they can look like warm autos, and you just need to really make that clinical correlation.
Yeah, I will say, I think drug-induced hemolytic anemia is probably underdiagnosed in that group, because it was, I think only a third of the patients had drug-induced hemolytic anemia. But these patients are really complex. They're on like 10 plus different drugs, usually like on and off antibiotics. So it's really hard to pinpoint one specific drug as the cause. All right, are there any questions online or? Oh, okay. No? All right, great. Thank you, everyone.